Welcome to the Resilient Performance Podcast. I'm your host, Doug Kachijian, and today I'm joined by Mike Lauria. Mike is currently completing his final semester at the Dartmouth University School of Medicine. Outside of school, he works as a critical care flight paramedic and provides training to multiple emergency service organizations. Prior to medical school, Michael served in the U.S. Air Force as a pararescueman at the 321st Special Tactics Squadron in Mildenhall, England. During this assignment, he deployed to Operation Iraqi Freedom as part of a combat search and rescue team and in support of the Charlie Company, 1st Battalion, 10th Special Forces Group Airborne. In 2009, Michael was named Air Force Special Operations Command Outstanding Airman of the Year and Pararescue Airman of the Year. I've been wanting to speak with Mike for a while here because he has drawn upon his experiences in military special operations and civilian emergency medicine to create a performance model that incorporates things like skill acquisition, psychological preparation, stress management, and interpersonal dynamics. As you'll see, Mike reminds us that most fields are trying to solve the same sets of problems, and that professional collaboration might be the key to creating better specialists. All right, Mike, thanks so much for coming on. You've got a pretty interesting background, having worked doing emergency medicine in both the civilian world and in the military. And even in the military, your job was much more tactically oriented than what your current medical position is now as a civilian. So I just wanted to start by asking you about what do you think from like a medical standpoint that the civilian world and the military does well or not so well relative to one another?
Yeah, no worries, Doug. Well, first of all, thanks for having me. It's a pleasure and an honor to be here. And to get right to your question, as far as the civilian and the military world go, I think that there is so much from each of these groups to learn from one another. In fact, like one of my favorite quotes that I think is often attributed to Thucydides is, but was actually said by Butler, I believe, was the state that separates its scholars from its warriors will have its thinking done by cowards and its fighting done by fools. And I think the same is absolutely true for medicine. So from the military perspective, we have a lot of exposure to trauma, really bad trauma, and relatively high volumes, perhaps not per operator or per medic, but overall, the data that we're able to capture and the things that we're able to do in the field, we have a lot of exposure to trauma. That said, a lot of it is in the field. So when it comes to out of what we would consider the traditional hospital setting and pushing care forward, the logistics of how you do that, I think that the military has a lot to teach the civilian world in terms of improvising, adapting, and overcoming in situations where you have very limited resources. I think the military has a lot to teach us in terms of logistics and flow of patients from point of injury to initial resuscitation to critical care evacuation and treatment. I think the military has that down. And I think something else which has sort of evolved out of the very nature of we're sort of pushed to our limits in these very extreme circumstances in this is this sense of we are pushing the limits of what is possible because we're doing it for our friends and our fellow soldiers. And so there are things that I think come out of very unfortunate circumstances where we're able to push the limits of what we currently do and try out new things and be very progressive in certain areas, try out new therapies, because in some situations we're just between a rock and a hard place. And it's like, you know what, I've seen this work in other circumstances, but what if we tried this piece of equipment for a new application? Because if we don't, the dude's going to die. He's going to die in the middle of the desert here. So why not? And I think that's reasonable, and I think that's helpful. On the other side of the equation, I think the civilian world can teach us so much. And I'll point out, I would hasten to add that it used to drive me nuts when I was in the military when people would say, hey, we don't do things that way. The way we do things is tactical, and that's just like the civilian way of doing things. They don't quite get it. And then leaving the military, when people in the civilian world are like, well, that's what you did in the military, but that doesn't apply to the civilian world. And I think both of those statements are wrong. Now, as far as what the military can learn from the civilian world, the civilian academic world, I think, has brought a lot of these concepts under has brought academic rigor and scrutiny to a lot of various concepts to refine them, to say, yes, there's really evidence here that this works in certain situations, but maybe not these situations. So while we might say, hey, like this particular therapy may be great in trauma, the civilian world is really great at saying, you know what, it might work really well in this population, but there's really not much to say or much evidence to support it here. Likewise, I think the civilian world is full of way more options, because we grow up in the military, and I'm just speaking from my perspective as a pararescueman and my limited exposure to other career fields, where we get trained a certain way and we get used to working with a handful of different options because, quite frankly, we can't carry that much, or our ability to use different pieces of equipment is limited, and our training time with that equipment or medications is somewhat limited, right? But when you look at the civilian world, there's all sorts of surgeons and anesthesiologists and emergency physicians in practice using all sorts of different effective, safe, and successful medication regimens or specific techniques or tools and tricks to accomplish the same goal. So it's more than once, I can say from my experience, where working on the civilian side of the house, you're like, oh man, that's actually a really cool idea, but I never learned it in the military. And that's totally applicable because it doesn't require a lot of more equipment or anything like that. It's just a new way of doing things. And so opening up your mind to those new sort of capabilities, I think is fundamental and definitely comes from the civilian environment. The other thing is different populations. While I think it is rare that in the military we run into little kids or old people with multiple comorbidities, that is something that you don't get a lot of exposure to. But you get in a pickle or you get in a hard place where you actually have to treat like a 3-year-old or a 5-year-old or someone who's really old. It is different from treating a healthy 22-year-old SEAL or PJ or SF guy. So that information from the civilian world, I also think is really helpful. So I think that they're not in opposition to one another. They're not two separate entities. They really can be very symbiotic in a sense.
Yeah, for sure. That was a great explanation, and I think that, like you said, these two things aren't dichotomous, and in many ways they're actually complementary. And you've actually you've done quite a few lectures at different conferences, and even on YouTube. And I'm going to put the links to some of those lectures. And you talk a lot about what the medical world can learn from, not necessarily like medicine in the military, but just combat in general in terms of some of the systemic challenges like interpersonal dynamics, leadership, and stress management. So from that standpoint, how do you think that not military medicine, but just combat or the tactical environment in general has to do, how does that relate to medicine, would you say?
Yeah, so that's actually a really good question. And I think that when people think of those two environments, especially, actually, I should say it in either case, when people in the military think about medicine and when people in medicine, especially acute care, so like surgery, anesthesia, emergency medicine, resuscitating people that are critically ill or injured, think about the military, it really seems kind of disparate, right? Like, how does working in an emergency department at Bellevue have anything to do with, assaulting some mud hut in Tal Afar, right? However, when you break it down, you begin to look at it, especially the psychological and cognitive aspects of working in these environments. They're actually somewhat similar. I mean, if you think about it, lives are on the line in both circumstances. Granted, hopefully in the emergency department or the trauma bay in New York or LA, although possible, it's unlikely, people are going to be shooting at you or trying to blow you up, right? But lives are still on the line based upon the decision you make. A lot of the time, the timetables are truncated, so you have to make time-sensitive decisions. A lot of the information that you would like to know, both in tactical situations and in emergency medical situations, is unclear. You don't have all the facts. You don't know what medications this guy is on. You don't know what medical problems they have. And so when you look at the how we make decisions in those environments, and you look at how we think in those environments, I actually think they're more similar than we may think otherwise. And I think there are absolutely lessons that we can adapt. I don't want to say directly apply because it is a little bit different, but there are things that we can adapt from the military that I think would be really beneficial in medicine, in particular because the way that we functioned operationally, we did it that way, and we didn't have any fancy academic name for it. We didn't call it anything other than trying not to die, right? Like, we go through these checklists, we do certain procedures, we drill certain things into people's head. We go about making tactical decisions in a particular way because over time we've learned that in the combat environment, that's how we stay alive. Because it's a very powerful motivator, as it turns out, what emerges is ways of doing things that I think are very, very helpful and could be applied in emergency medicine. So, for example, when we're in the aircraft, right, when we're coming in for a landing, there's triangle talk between the pilot, the co-pilot, the gunner, the FE, and the PJs in the back, right? When you're at 50 and 50, as soon as the pilot says 50 and 50, so we're at 50 feet, 50 knots, right? Immediately what you hear is clear left, clear right, and someone in the back says clear back, right? So that is generating an active circle of awareness. And as soon as you get cued, everybody is looking around and seeing what's going on and pitching in that, okay, it's clear. So everybody knows that you're clear around the aircraft. That's a fantastic communication tool, and there is, I think, evidence in the civilian side, not necessarily in medicine, but in other areas, that various structured communication tools and ways of doing things can actually help us maintain our situational awareness in really, really busy situations, which would not come as a surprise to people who fly in a combat environment or who are on the ground in a combat environment. But in the emergency department, that kind of talk in certain key, shall we say, procedures, and sort of the archetypical one that I use is airway management. So when you're performing rapid sequence intubation, I think can be helpful. Likewise, when we look at aside from communication and situational awareness and a host of these other human factors, one of the things that I've tried to hone in on is actually look at some of the performance psychology things that I noticed that our colleagues in the special operations world, I mean, they didn't necessarily go to the sports psychology literature and check out a book from the library and read all the studies, but they've adapted some very interesting tools over time to help stay focused and to help stay motivated, to help themselves think more clearly in these really stressful situations. And as it turns out, when you look at the civilian literature, there's actually a lot of evidence to show that this stuff works. So that, I think, would be another example of things that we can take from these very high-risk occupations and actually apply them to medicine to help us be more efficient and safer with our sickest, most injured patients.
Yeah, and like you, I kind of transitioned from the military to a pretty demanding civilian medical academic program, and it kind of made me realize that in the military, you don't get nearly enough reps as a medical provider because you have so many other responsibilities. In our case, it was things like scuba diving and parachuting and small unit tactics and technical rescue. So we're not going to get the same amount of patient contacts as, say, a civilian paramedic would have, or somebody that works in an ICU. But I felt like even though I might not have been competent as a pure medical provider, I think that what compensated for some of those deficiencies and lack of patient contacts was the way that the military systematizes what it does, and having things like standard operating procedures, and then even the way that the military encourages you to work as a team, and having some of these, fluid leadership models, whether it's top down or bottom up, depending on the situation, and working better as a team, like I said, allowed someone like me who might have been lesser skilled than somebody who was practicing medicine every day. It allowed me to complete a mission successfully without having that many patient contacts. So I think that if we could somehow sort of combine the way that the civilian medical system does things with, more rigorous residencies and patient contacts, and then combine that with some of the interpersonal and logistical type models that the military espouses, I think you could have a pretty powerful combination. So we talked about how the military is really insistent on using models to simplify some of these complex phenomenon. Talk a little bit about how you use mental models to facilitate communication, because there's kind of, in some circles, a little bit of a backlash against models, because every model is inherently an oversimplification, and people will say, these models are just constructs and they're made up, and it's almost like you can criticize it to the point that you're almost a little bit of a nihilist. But if we didn't have these models, how would that affect our ability to communicate and sort of speak a common language in things like medicine or even in the military?
Yeah, so I think that's a really good point, and this is always one of those things that I just get up on a soapbox about, because people will say if we were oversimplifying things, if we distill things down to these very simple models, we're missing a lot of the nuance, or we're just dumbing it down for people and we're lowering the bar. And I think those people are missing the point for a couple reasons. One, developing mental models for communication, for technical skills, performance, or just about for anything is the way that we as a species have survived. Like that is part of our brain's natural way of doing things. We condense things down into a mental model. People say that a picture's worth 1,000 words. A model is worth 100 million lines of brain code, if you will, right? Because if you think about it, the nuanced steps of doing something as simple as kicking a soccer ball or hitting a tennis ball or tying your shoe, right? If you were to think about those discrete steps, that would be essentially impossible. We'd be so slow. You wouldn't be able to perform at a very good level. And in fact, you'd probably end up, this is my hypothesis, I have no evidence to suggest this, but you'd probably end up overthinking things and sometimes screwing things up. And I think a lot of athletes have been in that position potentially. So what we've done over time is our brain has condensed these concepts down to mental models that revolve around a bunch of different things. So for me, when I talk to medical people and I'm telling them about mental models, I say, if I say the word ventilator to you, right, that engenders various mental models, and it could be, how we ventilate someone to protect their lungs from getting overinflated, how we protect someone or how we ventilate someone who has a very low blood pressure. That mental model also includes, when I say the word ventilator, right, you think of your ventilator, the one that you use on a regular basis. You know what the buttons look like, you know what the display looks like. So these models are your brain's way of taking very complex psychomotor skills and sort of information, knowledge, and combining it into a model that revolves around whatever it is. That's number one. As far as distilling it down or oversimplifying it goes, what we actually know is that if you look at people in very time-sensitive situations that are trying to make complicated decisions or life and death decisions, if you do the thinking beforehand and you say, given these circumstances, 98% of the time it's going to fall into one of these three categories, and this is how you respond, versus giving you the entire spectrum with all of the nuance and all the possibilities and say, make an effective decision to save this patient. That when you limit those options in certain situations that are very time critical, people actually are more efficient and they perform better. So distilling things down to relatively simple models can be really, really effective in some of these high stress situations, because you're relying on this sort of cognitive pathway that doesn't involve a lot of frontal lobe higher level processing, which we know is actually impaired in very stressful situations. So I think it's good for a variety of reasons. It works with sort of our natural physiology and the way our brain tends to process things. If we can be smart about how we design and teach those models, then we can develop mechanisms that allow people to perform quickly, efficiently, and safely in very high stress situations.
Yeah, and we make a lot of decisions based on pattern recognition, and it would seem to me that these mental models are just ways that we utilize these patterns to make information less overwhelming. Because if we had to effectively, recreate like our decision-making process every time we encountered a relatively novel situation, it would be complete chaos, right? So it's like, yes, there's a certain degree of oversimplification, but effectively with these models, it seems like we're playing the probability game. We're not saying that these models explain everything, and every model is probably inherently wrong, but we're playing the probabilities. And then people, I think, who are critical of models, I think that sort of the false assumption is that these models are fixed and can't be refined, so that just because we're using a particular model at this point in time to describe a phenomenon doesn't mean that we're not going to try to evolve that model to make it more encompassing. I think that the idea that these models are static and that can't be changed, but the idea that we shouldn't have any models, I just don't know. It would be so paralyzing and overwhelming. I don't know what we would do, especially with like some of the environments that you've worked in emergency medicine and in the military. Like when you're under canopy and your main parachute doesn't open, that's not the time to create a new emergency procedure from scratch. So right. These things all have a time and a place. However, one of the ways that our models sort of get tarnished is through cognitive bias. That's something you've spoken about at length in some of your YouTube videos. So can you talk a little bit about what cognitive bias is, and then how we can better refine our models without falling prey to cognitive bias?
Yes, that's a really good point. Before I answer that question, you brought up one really good thing that I wanted to add on to, and I didn't mention, is that I could not agree with you more. Most people think that, or I think when they critique it, they think of these models as being very static. And you made, I think, the very good point of pointing out that they can be refined over time. In fact, when you look at how people refine those models, that is what some people believe key to expertise. So if you read some of the research that's been done by Anders Ericsson, who recently, several years ago, I think, published the book Peak. He studied expertise his entire life in multiple domains. And one of the things that he and other colleagues believe is that one of the things that leads to higher, more efficient performance is what he actually calls it mental representations. But when you look at it, it's essentially the same thing as mental models, are very carefully refined over time. And the more refined these mental models become through sort of trial and error and practice and training, it leads to higher levels of performance and is certainly associated with high level performers. So that said, to answer your question about bias, I think that we get into trouble when we stand at either end of the spectrum and think that we have to very carefully analyze things, or we can just go with these mental models all the time. We can just go with intuitive decision making and our gut all the time, versus we have to very carefully analyze things all the time. And in fact, I think that advocates of both sort of cognitive mechanisms, if you will, decision-making mechanisms, would really make this argument out to seem like it was one or the other. And I don't think that's the case. I think it's a blend of the two, right? So there are definitely times when intuitive decision-making is very, very helpful, and can help us when things are relatively uncertain, when we have to make decisions very quickly. There's a whole host of features that actually outline when it's actually very helpful to use intuitive decision making. Contrast that with the analytical decision making, right? There are also very good times when that is helpful. So very emergent times, care under fire, for example, not the time where you should be putting your thinking cap on and, doing a lot of analytical thought process. Conversely, when you have someone who's at least relatively stabilized, or you have them in the back of a helicopter and you're effectively moving them from point A to point B, and all you're doing is medical care, you can actually have the time to very carefully think through a treatment plan and what you want to do, and refining dosages of medications and all that other stuff. Your question about cognitive bias points at what has been the primary criticism of intuitive decision making, right? So there's a whole host of sort of classic cognitive biases that people fall into, and we can see them on a somewhat daily basis, right? So you think of people that go, this is sort of a classic example, people who go to a casino, right? And are at the craps table, and someone just rolled a 7, right? Well, I'm going to start betting some cash. Someone just rolled a 7. I mean, what's the likelihood that someone else is going to roll a 7 right after that, right? Our failure to calculate and think about the odds can hurt us there, right? Because it's every single roll, the probability of rolling a 7 doesn't change from roll to roll. Right. So really, without thinking about it, you fall into that cognitive trap and you could lose a lot of money. There are all sorts of other ones that have been described in the literature. For example, people talk about a recency bias. So if we have if we go on the ambulance, 5 times for people with chest pain, right? And the first guy with chest pain, second guy, all the way up to the 5th guy with chest pain turn out to not have a heart attack, right? The 6th person we go on who's complaining of chest pain, we tend to think it's they don't have a heart attack, because we've been exposed to people who had similar complaints and didn't have a heart attack. That can influence or skew our thinking with that 6th patient. Likewise, with an anchoring bias, you anchor to a diagnosis. For example, it's oh man, this guy must have a pneumothorax. He must have air in his chest, which is giving him problems breathing, right? If you operate under that assumption and do a whole bunch of treatments and they don't work, right? If you fail to actually reconsider the possibility that, wow, I tried 5 different treatment modalities to fix the air in his chest and nothing worked. Maybe it's not a pneumothorax. So if you don't stop and think about it, then you can fall into that trap. So how do we avoid those cognitive biases, that primary weakness of the intuitive decision-making thing? Well, I think the answer is there's a number of things. It starts with understanding those biases and understanding, if I'm not careful in application of this intuitive decision-making and I don't use it judiciously, then I can fall into one of those traps. This is how those traps sort of manifest themselves for each trap. And then knowing, for example, for you or for me, when I'm really busy, tired, or I'm hangry because I haven't had anything to eat in 12 hours, what traps do you tend to fall into? Which cognitive biases do you tend to fall victim to? And then using things like effective team dynamics, if you and I were partners and we're flying this critically ill patient, from point A to point B, and it's man, they're still hypotensive. Their blood pressure is still really low. We've been operating under the assumption that it's because this patient needs fluids. It's because they're hypovolemic, right? But after liters of fluid, the blood pressure is still not coming up. right? One way to avoid that cognitive trap of like chasing the blood pressure and thinking this person just has low blood volume or they're dehydrated or they're hemorrhaging, right? Is to be like, hey, Doug, like we've given this lady like 3 or 4 liters of fluid. And I know we thought like originally she may have been really sick and septic, but I think there's actually some information that suggests otherwise. Like, what do you think, man? Check me on this one, right? And you chime in and you're like, actually, that's a good point. You know, they did mention this at the outside hospital, or we did see this, that, and the other symptom. That doesn't line up with the picture that we thought. So using effective team dynamics can be part of that too. So I think those are like the initial strategies, and there's a handful of other less high yield ones too.
Yeah, what's really interesting about that is because the intuitive versus analytical thinking is just, again, another model. And, you know, all models are incomplete. And I think it's great that, you know, we as human beings evolved a way that in emergency situations, we use pattern recognition to make decisions because where time is more important than necessarily accuracy. And then we have this other sort of system, if you want to call it that, where we can be much more analytical when time isn't of the essence. And we're much more likely to look at context and be nuanced. Whereas those things, you know, context and nuance, when you have to make a decision right now, can be somewhat debilitating. But I think from a training standpoint, what's fascinating is the way that these two systems can potentially blend. So I don't know about you, but I remember like the first time I learned like urban warfare in the military, we have to go into urban areas and clear structures. You can use your implicit biases against yourself. So like the instructor or whoever's running the course would put like a picture, you know, a target up, and it would be someone who looks like a terrorist. So use whatever stereotype in 2018 looks like a terrorist. Someone who looks like a terrorist, but there's someone who's like, let's say, an innocent-looking woman holding a gun and pointing it at the terrorist. We have these implicit biases, these cognitive biases, oftentimes that we're not even aware of. And you know, in our group in the military, there are people who are presumably selected for their physical ability and their intelligence. And when they're not trained in this specific endeavor, they fall prey to some of these biases. And even though, you know, they know on an analytical level, like you should only shoot the person who has the gun that's, you know, has a threatening posture, you'd still see people with the simunitions or the fake bullets. Like they would immediately, like their brain would recognize, oh, this person looks like a terrorist. There's a gun somewhere on the target. But instead of focusing on the hands, you focus on that immediate recognition of there's a terrorist, there's a gun, and they shoot the wrong target. But that's trainable. And, you know, like over time, as you get better at these skills and you do your runs and you slow things down, you're better able to differentiate, you know, your target and focus on what really matters, not like some of these biases. So I think it speaks to the fact that even when we have these like system 1 and system 2, as Kahneman calls it, I see them as much more fluid than dichotomous, because I think that we can train ourselves, if we manipulate the environment well, to maybe make something that would normally be less accurate, more accurate and more intuitive at the same time. So have you seen that in your experience in medicine, where something that maybe was a little bit more analytical initially through training could be more intuitive and more accurate?
Yeah, absolutely. 100%. I agree with you. And I always tell people, and just to reinforce kind of what you had said, that it's sort of more on a spectrum and less dichotomous. It's not like our brains evolved with like one switch that says intuitive and one switch that says analytical, right? Those are sort of necessary academic structures and descriptions that we've used to effectively define and then study these things. But you're right. I mean, it's not one or the other. We kind of use both. Like going back to the CQB example, you know, if you're moving through a house in a hallway and clearing rooms, you're very often using intuitive decision making because you're flowing through that house so quickly that you don't have a lot of time to stop and really think through all various options, you're moving very quickly, either to save your life or someone else's, or to neutralize the target or whatever, right? But you definitely get to certain points, like you clear a floor or you clear a building, right? What are you going to do next? Where are you going to go? Are you going to go up to the roof? Did anybody clear the basement? Right? You inevitably hit these points where you have to sort of information and then analyze it and decide what the next step is. So even in these combat situations, right, we're using intuitive and analytical decision making in series or in parallel sometimes with different groups of people, right? The commanders thinking through higher level things like where they want to move the team next. What are we going to do here? While the team is sort of flowing to the building, clearing room to room. So that's number one. Number two is I totally agree with you. It is trainable, right? And that it has to do with you can apply kind of how I mentioned earlier. You can absolutely apply the analytical decision making or the analytical thinking modality to think about things beforehand, and that drives your intuitive decision making or your fast decision making, right? So going back to I think you brought up a really good example, right? You're so used to seeing like a picture of a terrorist and what they look like. So when you see like the little old lady, you don't think she's a threat, right? You think she's like on the way to the store to get milk and cookies. But as it turns out, they've pasted or painted or drawn like a gun in a lady's hand. So what are they trying us to do, right? They train you to look at the hands, right? You identify the target, and as soon as you see the target, you look immediately search for their hands. So that is a trained behavior that becomes intuitive if you train it properly and can help you solve that problem when you have to make decisions in the order of seconds or fractions of a second, right? Likewise, in medicine, I think we can do the same thing. There are various situations, some very obvious situations, right? So, for example, when it comes to people that go into cardiorespiratory arrest, right? We don't stand there and think about like, wow, this person fell down and they look blue and they're not really breathing. I wonder what's going on with this person, right? No, we actually train people to, as soon as you realize there's no signs of life, start chest compressions, right? Because we want them to respond immediately. It doesn't really matter at that point what the underlying cause is. If you leave them without a pulse for very long at all, the game is over. So just start pushing on their chest, push deep and push fast, right? We train people to a certain depth and push a certain rate and all that stuff, and that comes first. And then as soon as that's done, right, as soon as you got that stuff going, then you can start putting some other building blocks in place. We can start an IV, we can get some medications on board, and then we can start thinking about, all right, so this guy collapsed, but what happened beforehand? Like, was he clutching his chest? Was he complaining of chest pain? Does he have a history of heart attacks? Has he been taking like way too much medication? Is there a possibility of overdose? Was this some other problem? Did he get hit by a car? Whatever. Like solving the underlying problem comes secondary. So I think we can effectively train those behaviors to optimize our intuitive decision making, but at the same time avoid some of those cognitive traps by combining it with analytical decision making. And I think the CPR example is a relatively straightforward one that most people may be familiar with, but I think there's a lot of others that we're trying to develop or have already developed in medicine, especially emergency medicine.
Yeah, and people like you are trying to bring things like debriefs to the medical world. Debriefs are obviously, or hot washes, or kind of like, pretty much after every training scenario or mission, everybody gets together as a team and tries to sort of deconstruct what happened and then come up with solutions to future problems. One thing that's really interesting, whether it's in in combat or in medicine, is you've got these individual skills that could limit performance, and then all these interpersonal dynamics. So when you debrief, let's say like a cardiac arrest case in medicine, or some kind of a trauma when you were doing your aeronautical evacuation stuff as a civilian or in the military, when you debrief these incidents, how are you going about differentiating, if you had a poor outcome, whether that was the result of like an individual skill issue, or maybe it was something that was, more systemic in nature, or a combination of both? That seems like a really difficult thing to do. Sounds easy in theory, but difficult to do in practice.
Yeah, exactly. And I think I wish I had like a really good answer for it. Unfortunately, I don't think I have a great answer for it. As myself, I'm still trying to like work through some of these things. And I think even in people who are like way smarter than me and study a lot of communication in medicine, simulation in medicine, all that stuff, they're still trying to crack the nut on this as well. I think there are actually some people in medicine who would say it's much easier or pretend that it's much easier than it actually is. There are ways to do it, like bigger institutional ways of doing it, like root cause analysis and all that other stuff. But if you were to boil it down to the scenario you gave me, where you're in a room and you just finished a medical scenario, I think it is kind of hard. And really, I think that the one thing that I found to be at least reasonably helpful so far is two things. One is patterns. So like if I notice that multiple people are doing something a certain way and you're like, well, why are they screwing it up like that? And then you see different individuals that you know are like intelligent, smart people screw it up that way. You're like, that doesn't make, like, either they're hanging out with one another 24/7 and somehow over time they've developed like the exact same habit when it comes to mixing medications or intubating or whatever, you name it. Or we've taught them wrong, or something has happened systemically that it's developed this pattern in multiple people. Likewise, if you see one person screw up a bunch of stuff over and over again, that obviously points more toward the individual side of things. I think the second is I really try to give people, when they make a mistake, the benefit of the doubt, especially once people have already made it into an organization that's really hard to get into. Like with our flight crews, the selection is very challenging. It's not the same as going through BUDS or going through PJ selection, but a lot of nurses and paramedics apply. Not many are chosen. And then there's a pretty rigorous 3-month orientation period. So by the time they get to the end of that, I operate under the assumption, for the most part, that these people are squared away. So when they do something that's wrong, stopping and talking to them, be like, well, what happened? Like, why did you think to do that? Well, I didn't really even realize that I did it. Or, I did it because I've always been doing it this way, because no one showed me how to do it, and I just started doing it that way, whatever. I think a sort of mini root cause analysis with an individual, getting to the bottom of it, can be really helpful too, to realize, was that a training problem? Was that a system thing that we're just all doing that can be fixed? Or is it like just an individual practice? I really try and be careful about these things, because I think one thing we've learned from the airline industry and a lot of the human factors literature is that we're trying to be more system-based, right? And not like dime people out and blame everything on one stupid or ignorant person. And we know that generally when things go wrong, that's not the case, right? It's a series of events and a lot of system problems that set things up not to go well. On the other hand, I think you and myself and probably a lot of your listeners can recognize that, sometimes it's just someone who's not too bright or screwed up big time. And the system itself is really pretty resilient. It's pretty strong. It's been working fine. And there really is no need to change it. But I think we got to be really careful about how we look at it, because getting to the bottom of which one is the bigger player, the system or the individual, is, like you pointed out, way more complicated.
Yeah, I think that's really the most honest answer, is like we really don't know, and it can be really hard to differentiate. And that's why, if you're constructing a training plan, like it's as much an art as it is a science, and you need to do a mix of part versus whole training, individual skills, and then kind of the full dress rehearsals. I often felt like in the military, they kind of overemphasized the scenarios at the detriment of individual skills. Like everything was, we've got to do it as a team. We've got to do it as a team. But if you're not cultivating the individual skills, you can have the best sort of, systems and procedures in the world, but you still need skilled practitioners within that system. And then when I switched over to like the civilian academic world in medicine, I felt like they kind of overemphasized the individual skill aspect, and there wasn't enough emphasis on like systems and interpersonal dynamics. So what that sort of magic, if it even exists, like percentage between part and whole training is, I don't know, but I think it needs to be both, and it's just really, really trial and error. But like you said, it's really hard to differentiate between those two things. So I think sometimes like I don't know is the most honest answer, and this is really, like you said, complex stuff, and because there are so many variables involved in these outcomes, to look for like a particular root cause, I think is oftentimes maybe even asking the wrong question versus just, okay, like how can we address all these factors through our training and then hope that kind of it comes together. I think people oftentimes are afraid to embrace some element of uncertainty, but I think we can delude ourselves when we try to have this really reductionist mentality where we say, okay, like this outcome went poorly because of this one thing. I think that can be as destructive as sometimes saying, you know what, we're kind of just guessing, but here's how we can guess in sort of the most informed way. So switching gears a little bit, because I think that, it's interesting talking to guys like you because you've had training from a variety of instructors and different learning models. And what's helped? You're all about, preparing for these high stress situations where you can't have any false confidence. Like you really have to go in knowing that you're prepared. What types of methods did you think best prepared you, whether it was things that you encountered in the military or in the academic world? Were there particular teaching styles or just, manners of presenting the information that you thought were more effective? Like what resonated with you the most from a learning standpoint? If maybe you can give an example of like a really good instructor or teacher that you had and kind of how they reinforce certain things for you.
So are you talking about just sort of preparing for high stress situation, or you mean like in general education?
Yeah, really in general. I mean, even just because just whether it's preparing to execute a physical skill or even just retaining information. I know in one of your YouTube lectures you talked about how like you were really looking forward to learning, I think it was respiratory physiology because you had a personal interest in it. But even though the topic seemed like it was really interesting, the way that the information was presented really tuned you out. And then you had another professor who taught you something you didn't have as much of an interest in, or at least you thought. But so how in some cases maybe the how it can be more important than the what. So the how you present the information can be more important than what the content actually is. So for you, like, what is the way to maximize the how? I guess that's what I'm asking.
Yeah. So, I think there's, this is like a topic of an entire hour-long conversation in and of itself. But I think there's some things that come from like academia. So we actually wrote a paper about some of these things. We called like the 5 T's. So when it comes to knowledge, like memorizing things or understanding information, between the reading that I've done and the people that I've worked with, I've come to believe that like the way I learn things on a time scale, for example, like if I'm studying or teaching, either way, try limiting it to like somewhere between 20, 25-ish plus or minus minutes of either studying or instruction. What we know is we can only process so much information, and then we get to experience something that cognitive psychologists call cognitive backlog. So that information kind of starts to pile up, and we don't necessarily remember it very well. So limiting the time, but also like if I'm really trying to memorize something or learn something, spreading it out over time. So like spaced repetition. So if I'm trying to learn about a particular drug or a particular procedure, revisiting it at intervals is absolutely very helpful. What helped me in medical school in terms of like memorizing huge amounts of information is kind of building it into mental models. So I actually would think of patient stories or patient context, patients that I've seen before in my life, but I didn't quite understand what was going on with them, or I didn't understand all their medical problems or comorbidities. But when I started to learn about them in medical school, you're just showered with information. And I don't know if that was your experience when you were getting your PhD, but like for me, man, it was just like a torrent of information coming at me, but organizing it based on patients that I've seen before and kind of putting it into context was really helpful. what else, man? Constantly testing myself and forcing myself to like recall information was a technique that I actually think came from the military and from my medical exposure before that, when people would ask me questions all the time, right? So like you're doing like a sand table drill. You're like walking through like a mission or whatever, and the boss, your team leader, is like, well, what are you going to do if this happens? What would happen here? What are you going to do here? What's the word of the day? What's the letter of the day? Like, they're constantly like quizzing you on stuff. Forcing you to recall information is actually really important. Basically, finding those neurological pathways is critical to you being able to recall it when it really counts. So actually, I started continually quizzing myself like all through medical school, sort of mini quizzes, with like flashcards and stuff like that, which we're not exactly sure how well they work, but also like formally like testing and doing lots of practice quizzes for myself. So that's like knowledge and information. But I think that you had mentioned before, and I think this is so critical and something that medicine is not, or at least the clinical part of medicine that I've been experiencing is not big on this, is when we were doing like skills, whether that was weapons training or whatever as a PJ, we would practice over and over and over and over again the manipulations of the weapon system, all these various skills, putting a tourniquet on hundreds of times, I don't know, thousands of times, which seems like very relatively straightforward skills, but to get really good at them, you had to kind of practice them from the bottom up. And at least in clinical medicine, I don't see that very much. I think that's something that I would like to bring, to the extent I can, into clinical medicine, is working on a lot of these micro skills and building up the abilities. I think is really important. We don't do that because from an academic standpoint, we're like, like you can do it. You look a lot at the big picture of a particular procedure, and very rarely do we focus on going back to the drawing board and spending 2 hours just working on the various micro skills that are involved in, say, putting in a chest tube or a central line or something like that. So I mean, I can go on and on and on about the teaching stuff that I've learned, but those are just like a handful of things, I guess, that stand out in my mind.
No, that's good stuff. And I want to finish with one more question, which is, I'm always interested in how to select talent for a particular profession. So, for like pararescue or to be a surgeon or to work in the emergency room, there should be a relatively significant barrier to entry. But oftentimes I wonder if the way that like these professions are selected really reflects the people who are going to perform at the highest level once they're working in those fields. So like in pararescue, for example, like the indoctrination course is how people are, even if they don't call it a selection course, it effectively is. And I think that it works well because, your ability to hold your breath in a pool, it might have some carryover to, say, diving, but I feel like most of the physical stress they put you through is really a proxy for other things that they can't test as directly, because you can't test, the ability of someone to jump out of an airplane or perform a skilled medical intervention in the dark when people aren't trained in those things. So you might, induce a lot of physical stress and sleep deprivation as a way to sort of mimic those things so that you're not investing a lot of time and money in people who lack at least like a physical or a psychological baseline to do the things that you really care about. So in the military, it kind of makes sense. And I think that, I did a whole podcast episode on this, but I think that the selection courses generally work pretty well for what they're trying to do. But in medicine, it seems like, even in medical school, or like when I did my doctoral education, it seemed like I often confused whether I was getting an education or if I was still being selected. There's a lot of rote memorization. You get tested on things that you could look up on a smartphone in 2 seconds and that maybe, don't have a whole lot to do with clinical decision making or executing a particular skill. Even to get into some of these programs, whether it was like, medical school or physical therapy school, you've got to do things like organic chemistry, and none of us are synthesizing chemicals in a lab. So it's kind of like, what do you think is the low-hanging fruit in medical education? I know it's a loaded question and we don't have a lot of time, but do you think that we're going about educating and selecting people for some of these higher level medical positions the right way, or are we kind of confounding selection with training by just still focusing on this quantity of information, not necessarily on the things that have the most carryover to like running a cardiac arrest code in the emergency room or doing a surgical procedure? Do you think that the things that we're emphasizing, whether it's with the board's exams or these seemingly arcane classes like organic chemistry, are really testing the things that we want to be testing?
So that is an awesome question. And you're right. It is totally loaded. And it is, I can see how it could be the subject of an entire podcast because it's a lot of stuff. I'll take a stab at it here. So I think, first of all, I would say that I can speak only for my education in medical school, but it seemed to me that at least like once you got in, it was much less of a selection in terms of the fact that like they didn't want you to really drop out. They want to retain people. And so I think despite the fact that there was just a ton of memorization and stuff that I would argue is not of the greatest utility, I didn't feel like it was a selection through medical school. After we were in, I did feel like it was, education and training, quote unquote. That said, I think there's a lot that can be done to improve it. There's a lot of stuff that's going on in the works, I think, to develop medical education. And we have some really smart people across the country at various institutions, at least for like in allopathic and osteopathic medical schools that I know of that are working hard to change that curriculum. Going back to the selection, like, are we looking at the right metrics to say this person will be successful or not? I think it's really hard to say because you develop a lot of really good physicians and some people that have certain interpersonal challenges or various other challenges, shall I say. It's always a bell curve, right? So there's always going to be people at the top and always people at the bottom of the curve. Largely, are we creating hundreds and thousands of incapable, untrained physicians? I think it would be hard. I think it'd be really hard to make that argument. I don't think that's the case. That said, should we be looking at different things? Absolutely. I think so. I'll be the first one to admit I don't have a really great way yet or haven't schemed a great way to standardize this, but I do think so. And I think things you should be looking at biology and genetics and biochemistry and organic chemistry. Do you kind of need that to understand some of this stuff? Yes. Should we weight it as heavily as we do? I don't think so. At this point, the clinical portion of my training over the last year and a half, the number of times that I've had to know which chromosomal translocations are for some rare 1 in 500 million disease, zero, none. Right? The times that I've had to talk to a confused patient or a patient that didn't understand that was going on or convince them that this was a very important decision, or to help them, not necessarily convince them, but to walk them through a series of very challenging or the options and walking them through a very challenging decision that they had to make often. Right? Negotiating difficult personalities in the hospital, whether they be residents, attendings, other staff, or other medical students. How often do you have to do that? Daily, right? How often do you have to make practical decisions? For example, it's difficult for some of my colleagues that are much younger that went right through medical school. They've never had to select an insurance plan, right? A medical insurance plan. They don't know, they just assume that if I give someone this medication that they're going to be able to take it or they're going to be able to show up for these appointments, and don't quite understand what it's like to have to work multiple 12-hour days a week and think about the practical aspects of how we deliver care to individual patients. Those things are, I think, much more important ultimately. You do need a certain level of intellect to be able to pass the national board exams to become a doctor. But there are so many more things that are important. So how do we actually look for those things or test those things? I think some people have had various ideas over time. The thing is, it's very difficult and expensive to do big picture with 50,000 plus people applying to medical school every year. how we quantify that and make it fair for people so that we can compare and contrast different individuals is somewhat harder. I think many medical schools are starting to lean away from some like things like the MCAT and different like scores for undergraduate tests or undergraduate classes, because they actually have data that suggests that really there's not a whole lot of correlation. Like once you're over a certain threshold on the MCAT, for example, there's really no statistical correlation with how well people do on board exams and ultimately how good physicians they've become, right? So that's more and more, I think, being de-emphasized and being taken as a piece of the puzzle. What the ultimate answer is in medicine, oh man, I really don't know. Or how we can change the process to identify those things. Like how do you effectively measure in a very short period of time, like how someone interacts with other people? Like some normal people just have like a gestalt, like, oh, I could sit here and talk to this person, right? They're not completely inept. They're not somewhere on the spectrum and like don't pick up on social cues. You just kind of have that gestalt of like, okay, this person's like, I can talk to this person. They're easy to talk with. They may understand me. They looks like they're able to empathize with some of my challenges, whatever. How do you take that and quantify that and then apply that to the other 600 candidates that are interviewing at your medical school? That's much harder.
Yeah, no, you're right. I mean, it's really just a timeless question, which is like, how do we measure the things that really matter? And with all of the technological advances, we're getting much better at measuring things, but whether we're measuring the quote unquote right things is yet to be determined. And obviously, it's way too complex a topic for us to resolve in the amount of time that we have here. But I hope people can at least walk away with understanding that the worst thing we could say is, well, this is the way that we did it and it sucked for us, so it's got to be like that for everybody else. As long as we can agree that things can be improved and that, not everybody has to suffer because the previous generations did, I think we can probably agree on that. And as long as we recognize that certain questions need to be asked, I think that's a step in the right direction. So you've been really generous with your time, and we've only really scratched the surface about some of these topics that you've spoken about in great depth elsewhere. So where can people, learn more about you, and just what are some resources people can check out to see some of the really cool projects that you're up to?
So if you want, there's a couple different places. First is my website, so www.michaellauria.com. Feel free to check it out. Some of my videos are there, and links to other stuff, especially in medicine, educational resources and stuff that I kind of follow. The other is the website that I write for is called MCRIT. So it's just www.mcrit.org. It stands for Emergency Medicine and Critical Care. So MCRIT is pretty reasonably reaches a pretty reasonable size audience around the world, and that's where I post a lot of these ideas that I'm trying to translate from the military world and from other areas into medicine. And I always appreciate everybody's feedback, because I definitely don't have the answers to all this stuff, and I'm trying. And luckily, I've been blessed by having some really smart people in medicine who are open to some of these ideas, trying out some of these ideas, investigating some of these ideas. But I don't consider myself particularly intelligent on a lot of these topics. I just consider myself more of like an idea broker, like being like, hey, these are really cool concepts that I think can help us here. Let's try them out. So if people in the audience have other ideas, or think I'm doing it wrong, or have ways of making it better, any of these concepts, please feel free to reach out to me, because I'd love to hear what you guys have to say.
No, that's the whole point of why we're here. So thanks again for your time, and keep tinkering.
Yeah, no worries, man. Will do.
All right, have a good night.
Take care.